Hello, I'm Dr. Nicholas Colivas. I'm a professor of orthopedic surgery at UCSF, and I'm the director of the UCSF Meniscus Preservation Center. Today I'm going to talk a little bit about ramp lesions and show a illustrative case. So ramp lesions are tears at the meniscocapsular junction of the medial meniscus posteriorly, and they're typically seen with ACL tears. They're very posterior and have to be carefully examined at the time of surgery for instability and repaired if needed. On MRI, they're not always very easy to see. They sometimes are quite subtle, and so you have to have a high index of suspicion at any surgery on the meniscus, particularly ACLs, for these, and take a really good look for them. So in my practice, certainly always suspect a meniscus ramp lesion if I have an ACL tear, and I'll always look in the back through the notch to see if there is a tear. Some of them are stable and don't need repair, but many of them do need to be repaired. If they're not, they can cause significant instability of both the meniscus and the knee itself. So the case I'm going to present is a 30-year-old, otherwise healthy gentleman, no prior injuries to his knee. He was jumping down from a platform approximately 3 months prior to his presentation, and he felt a pop in the right knee, had swelling and pain. Some of that resolved over time, but he continued to feel unstable. His exam on presentation showed a tender medial joint line with some positive medial meniscus signs. A range of motion from 0 to 135 degrees, but some obvious anterior plane instability with a 2B Lockman and a positive pivot shift. His x-rays were unremarkable, a healthy knee, and MRI showed these findings. This is the sagittal with the meniscus appearing somewhat intact, although you can see perhaps a small vertical line at the posterior horn there. The rest of the meniscus just had some subtle change but no obvious tear. Here's another example here. On the coronal, however, you can see a line suggesting a vertical tear, quite peripheral, but that was only on one sequence. The rest of the sequences showed this sort of mixed signal change pattern. And the root also showed some signal change but looked to be intact. At the time of surgery, we were able to see this actually unstable medial meniscus, so this was clearly at a minimum a bucket handle type tear rather than just a simple vertical. And then putting the scope in through the notch, you can pull the meniscus aside and see there that there's a very large ramp lesion, in fact one of the largest ones I've seen, that extended medially but clearly was unstable. So I usually shave and then trephinate the capsule and the back of the meniscus here, and the key to these is to, if you're going to use an all-inside device, to actually be able to capture that capsule posteriorly. If you can't get it from this angle, you have to make a posterior medial portal and use a spectrum type device, but in this case we were able to get through the meniscus and into that capsule and then place a vertical suture into the capsule to really secure and pull a healthy chunk of the capsule up and onto the meniscus for the repair. Now usually I use 2 or 3 of these types of sutures to secure this ramp lesion. In this case, as I noted earlier, the ramp lesion was very large and in fact extended almost like a bucket handle type tear. So we actually then started suturing the remainder of the bucket handle medially with a combination of horizontal mattress sutures using all-inside device here again, and again after having prepared all the surfaces really well, so there's good bleeding when you cinch all of this down. You can see that happening. We also are able to place sutures inferiorly, not just superiorly, so that that meniscus sits down really well, and we're using a horizontal mattress suture there. We'll then continue with placing vertical mattress sutures all around the whole repair, so that we get a really strong, solid repair on these on this bucket handle type meniscus. And then actually return, in this case, to we make sure to also get the apex of the tear, so that this tear won't propagate any further, with a vertical mattress suture here. Once I had completed that, in this case I actually went back to the ramp lesion section, added an additional suture here to make sure we had that capsular tissue really well held up against the meniscus. And this all came together very nicely. So the final construct, once we had all the sutures in there, approximately half a dozen sutures there, very solidly repaired back up to the capsule, the meniscus completely preserved, and the stability of this meniscus very solid up against the capsule there. You can see the cartilage surfaces here are really good, so I'm optimistic this patient will do really well. We typically, when we do meniscus repairs, use a microfracture all, but in this case we're doing an ACL reconstruction, so we didn't feel we need to do a microfracture for growth fractures for this particular patient. So the post-op protocol I use for these patients is non-weight bearing for 4 weeks in a brace, where they're allowed to go from 0 to 90 degrees. At 2 weeks they can start weight bearing in extension with the brace on. After 6 weeks the restrictions are removed, patients can weight bear as tolerated. This patient is relatively recently post-op and is doing well. We'll see how his recovery goes. Thank you from the Meniscus Preservation Center.